Michael, thank you very much. I stand before you for two reasons with some trepidation. The first is that the room is full of people who know a great deal more about how to deliver health care, how to organize it, than I do, so I'm out of my depth right away. And secondly, I'm here with Dr. Jeffrey Turnbull, who knows more than probably all of you put together about how to deliver health care effectively and speaks so passionately. And I thank you, Michael, for referring to chronic condition. It's the latest in the long list of my instant rare books, so I appreciate you mentioning it. I have lots of unsold copies for anybody who wants to buy it. It's going for lower and lower rates with each passing month. But I did count very much on Jeffrey, who opened my eyes to many things that were going on in the Ottawa hospital in the time that I spent with him and with the staff. And I've seen him many times since, and he's a wonderful person, and I feel inadequate very much whenever I'm in his presence. I want to thank you for inviting me for two reasons. One is it's always great to be in Stratford, but secondly, because I tend to live most of my life either in big cities or on airplanes. And over the last 18 months, I've had a great opportunity to visit smaller places in Ontario and to talk to people and listen to what they have to say about the challenges in their particular part of the province. And I came here to Stratford about a year ago at the invitation of the Hospital Foundation. And I spent the better part of a day listening to folks in and around the Stratford Hospital, community folks who were helping the hospital, people who were working in the hospital. And it was extremely educational for me to do that. And I've subsequently had the opportunity to be in Perth to talk to the Lynns there just a month or so ago, and in Collingwood on several occasions, and in Peterborough, and twice now in this part of the province. And I can tell you, you probably know this, but boy, the world looks a lot different than it does in Ottawa and Toronto when you get about 15 kilometers outside the boundaries of those cities. Many of the challenges are the same, of course, but some of them are quite different, having to do with geography, having to do with an older population, a rural population. So I very much appreciate being here, and I hope in the break periods that you've, Michael, organized, that some of you will talk to me and I can learn from you. What I want to do this morning is to say a few words about where I think we've recently been in healthcare, and then talk about a few of the challenges, many of which are better known to you than to me. We're on moving day. I suppose that's a fair way of putting it. I hadn't thought of that metaphor before, but I'm going to steal it if you don't mind. Just a couple of things I think we've learned over the last decade about healthcare from sort of 35,000 feet, both of which are good. The first is, and the principal reason why I wrote that instant rare book, is that almost nobody anymore stands up in an informed group like this, as was the case 10 years ago, and says that Canada has the best healthcare system in the world. That has been belied and debunked by all kinds of international and Canadian studies, to the point where in polite company or an informed company, if you said that, they'd bring in the folks with the white coats and off you'd be taken to the nearest place you needed to be. But on a stage is not where you should be. And I remember, and we were chatting about this at breakfast, when Deb Matthews was the Minister of Health of Ontario, she would often say that we don't have the best healthcare system in the world. And when I first heard her say that, I was quite astonished, because political people didn't tend to do that because it was too risky. But she knew the facts, and she wasn't prepared to engage in bafflegab, so she spoke the truth, and all the more power to her. And that's a good thing, because you really can't have a serious discussion about anything, whether it's healthcare or education or whatever, if you don't start from factually accurate starting points, and now we are. The second thing is that we know that the answer to the challenges of the healthcare system does not lie, the answer does not lie necessarily in spending a great deal of additional money. We can all want more money for whatever purpose, and in some cases it's badly needed, and I'll talk about that in a moment. But the notion that the answer to the system-wide challenges is to spend a lot more money has been belied by the experience of the last 10 years, because over the last 10 years, it was decided that we should spend $41 billion additional dollars nationally in healthcare, indexed at 6%. That was the agreement. I wish my salary had gone up over the last 10 years at 6% a year. And at the end of the spending period, which is just coming to an end now, this is the last fiscal year, and things will change next year, we didn't actually get the kind of change that had been promised. You know, the word up on the screen a while ago was the transformation of the healthcare system. And the Prime Minister of the day, a man I like and admire very much, Paul Martin, used to talk about transformative change. And he thought, as did the others, that if we spent all this money, we'd get transformative change. And you'd be hard-pressed, anybody in this room, to argue that for all that money over the last 10 years, we got transformative change. And indeed, one of the small things that that money did was produce something called the Health Council of Canada, which was supposed to monitor how this money was doing. And the head of it was Jack Kitts, who is the head of the Ottawa Hospital. Now, the Harper government has ended the Health Council of Canada, but in its last report, as it summarized what had happened, it said this: "The experience of the last decade suggests that spending more money is unlikely to achieve the desired results. And although the resources to improve our healthcare system and the health of Canadians were made available, the success of the health accords in stimulating health system reform were limited. The decade saw few notable improvements on measures of patient care and health outcomes, and Canada's performance compared to other high-income countries is disappointing." So that was the last report of the Health Council that was supposed to monitor, charged with monitoring how effective this money had been in bringing about what had been promised, namely a transformed system. What was expected was that this money could buy change, but in fact it didn't buy change, it bought time, and it made various people in the system much better off financially. And even today, if we wanted to ignore the experience of that decade and go back to spending a great deal more additional money, the government of Ontario, at any rate, and the government of most of the provinces would not be in a position to do it as they were 10 years ago. 8 of the 10 provinces are in deficit, and the most onerous deficit is here in Ontario, $8 billion, and the government, assuming a lot of things, some of which are out of their control, anticipates a balanced budget only in 3 years' time. So the notion of going to the government of Ontario for anything, I mean, I sit on a university board, the University of Ottawa board, and we were discussing at breakfast, who's got tougher challenges, running a hospital or running a university or running a LINS? I mean, the money is not flowing. We're losing every year 1% of our base budget from the government of Ontario, and if you're running a hospital here, it's flatlined, etc. So anybody who thinks that in other sectors there's going to be a lot of money flowing is not paying attention to the situation. So for the last 3 years across the country, and Ontario has mirrored this trend, healthcare spending has been going down from 6 and 7% to 2 to 3%, which is a dramatic change. Now the question, if you were sitting at Queen's Park or you were sitting at any provincial capital, are we in this 3-year period baking into the system structural changes and assumptions and system adjustments that mean that we can sustain this level of increase for the foreseeable future? Because if we can, then the sustainability question of healthcare will disappear. We can, at 2 and 3%, without taking money from other programs, maintain a perfectly good healthcare system. Or are we just going through a period of X number of years when provider demands have been restrained, certain other changes have been introduced, but after X number of years, the pressures will build up again, and we'll be back on the kind of treadmill we just came from. And no one quite knows the answer to that question right now. Only time will tell. Don Drummond, when he did his report of a few years ago on the fiscal situation of the province, said that he thought the healthcare budget would eventually settle in at about 5%. The Canadian Institute of Actuaries says about 5%. I don't know. We're in the what did you say, the moving day. One of the parts of the moving day is to try to figure out whether what we're doing now is baking in structural changes to systems and assumptions, and it's too soon to tell. Are we living through a hiatus? But, just a little simple arithmetic. The population of Ontario grows at 1% a year. Inflation is about 1.5% for the moment. We don't know where it'll be in 3 or 4 years' time. Aging, which I'll come back to, adds about 1%. So before you have paid anybody any more money, or bought any more technology, or added more money for system improvement, you've kind of got a 3.5% inflation rate, just because of the normal inflation rate, because of aging, and because of inflation. So that's part of the challenges of this sort of moving day through which we are going. When you ask people what they think about the healthcare system, the results are not bad. For example, last year, the Commonwealth Fund and the Health Council of Canada, before it ended, looked at a public opinion data, and in Ontario, it said this. It said, how would you rate the health care you've received in the past? And in Ontario, it was positive. It was 74% of the people said that they rated highly the health care that they had received in the past. Then they were asked what they thought of the system as a whole. And the answer was, on the whole, the system works pretty well, and only minor changes are necessary to make it work better. And 50% of Ontarians said that. Only minor changes are necessary to make it work better. But about 40% said that far, far more dramatic changes were needed in order to make it work better. One of the major complaints, and Michael alluded a little bit to this, here and elsewhere, if I had to think of one thing that gets up the gullet of people in Ontario, it's access. Because when people were asked questions about that, in Ontario, 56% of individuals said that it was somewhat or very difficult to get after-hours care. And if you look at a study that came out last year, which was about 11 countries, 11 advanced industrial countries, all of which, except the United States, had largely public health care systems. On questions of access, unfortunately, we were last or second last out of 11 in every category. Able to get same or next day appointment when sick, very or somewhat easy getting care after hours, waiting more than 2 months for specialist appointment, waiting 4 months or more for elective surgery. In all of those categories, we either stood 11th or 10th. In other categories, we were kind of in the middle, and in a couple of categories, we were near the top. But this is the category by comparative standing where we still don't rank very well. So that's where kind of we are at the moment. One last thing I should say. All the provinces, and Ontario is going to face exactly the same challenge, next year, assuming the government is re-elected in Ottawa, and I'll come to that in a moment, the health accords are over, and the government has announced some time ago that rather than having the money it transfers to the provinces increase by 6% a year, it's going to be increased by nominal GDP growth. What's that fancy word mean? It means the rate of inflation plus population growth. So you're in at about maybe 3 or 3.5%. Economic growth and inflation. So you're going to go from 6 to 3 to 3.5%. Doesn't sound like much, But over the years, it's a multi-billion-dollar reduction. And the provinces are going to have to, unless the policy changes in Ottawa, are going to have to absorb that multi-billion-dollar reduction in the money they're getting from the federal government. And all the provinces are going to have to face this, and Ontario is no exception. So that's going to add additional pressure on the provinces. So I think the number one issue, and it was alluded to in those films, that we face as a society is, of course, the aging of the population that's going to go on for about the next 25 years. And although we talk a lot about it, and I read what I can about it, when I close my eyes and try to envisage what lies ahead, I really can't do it, because it's a world in which none of us have ever lived, but we're going to have to live through it. It's a society with a demography that none of us have ever experienced, and we are right now moving into this quarter of a century. We're probably 2 or 3 years into it, and all of the pressures that you see, that film and many others, all of these things are going to intensify greatly in the next 10 to 15 years. Today, 14.5% of the population is over 65. But by 2030, that's 15 years. That's not that long. That's 4 electoral cycles in political terms. The share is going to be 26 or 27%. None of us have ever lived in a society where more than a quarter of the population is over 65. And by the way, as you know, some of you who are health economist types, that 14.5% who are over 65 today take 45% of all the healthcare dollars. The OECD in Paris predicts that soon after 2030, 10% of Canada's population will be over 80. Today the share is 4%. None of us have ever lived or seen a society in which 10% of the population is over 80. If you want to see it, go where I just was, which is in Japan, because Japan is there now. And we're going to be there ourselves in a little more than 15 years. Now, the Department of Finance in Ottawa suggests that 15 years from now, in 2030, the average age for a woman, pay attention, females, the average age for a woman is going to be 87. And for men, 82.3. And that's about the historical average, in the sense that women have been gaining, on average, over the last 50 years, 1 year of life expectancy a decade. The Canadian Institute of Health Research, therefore, we've got an older population. CIHI did a survey 2 years ago and reported that 78% of seniors had one chronic condition, and 24% reported 3 or more. And at the top of those lists of chronic conditions were high blood pressure, arthritis, heart disease, and diabetes. Now, those figures sound scary. Just break them down a little bit. If we have today 15% or so of the population that's over 65, and about a quarter of them have 3 or more chronic conditions, that means, arithmetically, a little fewer than 4% of the seniors, which isn't bad, really. They are the vanguard of the multiple morbidity patients that must be, and increasingly are, the target of so many efforts that people in this room and across the country are making to focus healthcare resources, both human and monetary, on those multiple chronic condition patients. Some of you know the numbers. In Ontario, 1% of the patients take up 34% of all the spending. 1 to 34. And 5% of the patients take up 66%. 2/3. 2/3 of the money is spent on 5% of the patients. These are what are sometimes glibly called frequent flyers. And a disproportionate number of them will be seniors, and the numbers will grow. If you think about, and it was in the film, dementia, for example. It's estimated now that over 8% of the senior population over 65 has some form of it. And the raw number of people with dementia, therefore, the sheer raw number, is going to increase as more people join that older cohort. The Conference Board estimates that across the country today, there are 750,000 Canadians who are living with some form of dementia, and that number, in raw number terms, will double by 2030. So are we prepared for, institutionally and in terms of the human resources that we need and the financial assistance to families that we may need for a doubling of the dementia population over the next 15 years? Are we thinking that far ahead, or are we kind of scrambling to catch up with where we are now? And you know, many of you, if you leave the multiple morbidity patients aside and you just do averages, you know that the per capita healthcare cost for people my age, 65 to 69, in round numbers is $6,400, 75 to 79, $12,000, 80 to 84, $16,000, and over 90, almost $30,000. Now there's good news. Really good news. No, really good news. Really, really good news. I mean, journalists are supposed to purvey bad news, but I think I should bring you some good news. And the good news is that according to OECD surveys, that's the crowd in Paris that collects numbers for a whole bunch of industrial countries, 85% of Canadians over 65 report themselves to be in good health. And of all the OECD countries, of which there are 30, only New Zealanders have a higher answer rate, yes, we're in good health. So in this aging society, a whole lot of people, a whole lot of older people, the large majority, a very large majority in fact, are and are going to remain relatively fit and healthy. And that is a major, major societal accomplishment. If you go back 50 years and read about the health systems of 50 years ago, of course, people weren't living nearly as long, and many fewer people over 65. The notion that 85% of seniors, there being much smaller in number, of course, in those days, would report themselves to be relatively fit and healthy, unimaginable. That's a major societal accomplishment. It's great for individuals, of course. It's great for their families. It's great for society. And of course, it's great for the healthcare system. And as a result of that, when you read, as you sometimes do, loose language that says that we have a gray tsunami coming, yes, we're going to get grayer, that's for sure. But a tsunami suggests this great wave that knocks everything down and bowls things over and causes chaos. That's not what's going to happen at all. Health economists estimate that aging is going to add about 1% to the total health bill. And that's tolerable, especially if we design and continue to adjust our system or redesign it to target resources, as I said, to the 5% of the population that are using 66% of the total resources. And that means more than anything else, and governments are doing it here, and governments are doing it across the country, and it is absolutely the right thing to do, to put the emphasis on community and home care, to try to keep people away from institutionalized settings if they can, especially in their homes, and make technology our friend in this way. Just let me go back to the, I won't say gloomy, but the realistic side. So no gray tsunami, 1% increase in the costs, manageable to be sure, especially if we continue to redesign the system. But aging has another side of it, and that's the revenue side. You get fewer people working relative to those who are not. And most people are earning the maximum amount that they have when they're in the workforce as opposed to when they're not. So the number of people who will be generating the maximum revenue in their life as the population ages goes down. Put it another way, the number of people that the government can tax in order to pay for the additional costs of an older population, the balance has substantially changed. So let me just quote from the Department of Finance in Ottawa. And it said, going forward, demographic changes will make it increasingly difficult to continue to improve Canada's economic performance through increases in employment. Falling fertility rates since the end of the baby boom and continuously increasing longevity have resulted in the Canadian population getting gradually older. So this is the key sentence. The number of working-age Canadians for every senior is expected to fall from close to 5 over the past decade to 2.5 in 20 years. So there's going to be a halving of the ratio of people who are in the workforce to people who are not. And because the older workers have significantly less labor force participation, unless productivity really improves, which is the #1 economic challenge this country has, population aging is going to adversely impact economic growth. And an adverse impact on economic growth means more difficulty for governments, whatever their political stripe, park the partisanship, they're all going to look at this in the face, their ability to raise the revenues at current rates of taxation, and there's great resistance in the country to paying more tax at the moment, for reasons we won't go into, to pay for the additional costs of an older population. And many other studies have shown that. So, aging is the #1 challenge, #1 change, but there are some other things I'd just like to throw at you. And by the way, I'm very happy to answer questions for a few minutes afterwards if you have them. When we look ahead over the next decade or so, as we must in healthcare planning, obviously there are many unknowns. As the great Defense Secretary, I say great sarcastically, of the United States, Donald Rumsfeld, once said, there are many known unknowns. And then there are the unknown unknowns. What medical discoveries will there be? We don't know. What will be the state of public finances to underpin a healthcare system that relies for 70% of the revenues from the public purse? What demands will there be for certain kinds of human resources in healthcare? This has always been a very tricky business to sort out. How many physicians do we need and what kind? Nurses, nurse practitioners, we were discussing at breakfast, doctors, assistants, community care workers. How do we train them? How many will we need? And I want to just suggest a few trends that might change or might cause us to have to change our way of thinking. Trends that will wash over an extremely complicated system, because all healthcare systems are extremely complicated, and they're very difficult, therefore, to coordinate, let alone change. Now, perhaps I'm more sensitive to this than most people, because there will certainly be technological changes that are going to alter the relationship between healthcare institutions and those who use them, between traditional knowledge figures and people who feel that they can better inform themselves, and a widespread ability of people as consumers to demand and receive services in different ways. This is a hallmark of our new society, and this is more than moving day in this field. It has been moving day, and now we're going even faster. In my business, people increasingly don't consume information via newspapers. They consume it via apps and iPads, and even, as somebody showed me the other day as he read the Globe and Mail on his watch. You can bypass the information that we give you, and you can get it on Google, for which we don't get any money. You can just bypass the traditional supplier, even though we're trying to give it to you in new ways. You can say, I don't want to pay for it. I'm going to go around you and read it on Google. We used to think, in my world, arrogantly of course, that we as journalists, we had more information than the readers, we had more experience than all but the real experts, and therefore people would turn to us for some degree of judgment as to what constituted information that they needed and wanted to know. Well, that's history. In the universities, online learning is breaking down some of the monopolies that universities used to have. As people sign up for online learning courses from some of the great universities in the world, not some 3-bit place in the middle of nowhere, but from MIT and Harvard and Stanford and the University of Toronto. You've all read about taxi monopolies being challenged by Uber. Travel agencies are disappearing as consumers do their online searching for deals. Bookstores, alas, as we all know, in my trade, have shriveled as readers download material or they order books that come to their door 48 hours later with a 30% discount from Amazon. Online consuming is threatening, and believe me, will continue to threaten the traditional retail store, including the shopping malls that have sprung up all around Ontario and Canada. Government services are now almost completely available online. You don't have to go to a government office to hand in your CRA or to get your whatever you need from the government. You can do it online. So I simply ask, if this is happening in almost all areas of our society, why would it be that healthcare should remain immune from these revolutionary changes? In a world of consumer, call it what you want, call it demand, consumer empowerment, consumer whatever, consumer activism, the deference that's paid to established figures in various walks of life, including, I would suggest, medical institutions and those who run them, is going to wane a bit, at least somewhat. There's always going to be an asymmetry of information between trained professionals such as doctors and nurses and patients. Always. And there are always going to be many people who, regardless of what I've just said, are going to rely not upon themselves and information that they can agglomerate, but on those who have, in their view, all the information. But all I'm saying is that there's going to be some shift. That's all I'm saying, some shift. According to a research report, for example, from the health specialists at PricewaterhouseCoopers that a friend of mine, Will Falk, just gave me, and they have a very strong health analytical team there. When they do surveys, they find that 82% of patients are open to new and non-traditional ways of getting medical attention. 82%. 74% are open to a quote-unquote virtual doctor's visit. And I suspect, they didn't ask, but I suspect that would apply to nurses, etc. 55%, this is a shocker, 55% trust the internet more than they trust the doctor. 43% say they want to shop for health care. Now, these numbers are one survey, don't go to the bank on them. I simply mention them because they're indicative of a certain trend that is everywhere apparent, not just in healthcare. Limited hours at clinics or doctors' offices, long waits at emergency rooms. These are going to be circumvented by people who are searching and demanding better access online, by private providers, by facilities that are more convenient to them. Walmart's company policy is to become the biggest primary care location for patients in North America. They already have 52 service sites in Canada, 52, and more are on the way, because they reason that since so many people are coming to Walmart stores for everything else, why not have a family health clinic right there where people can park, go to the clinic, and do other things? And the doctors like it because Walmart takes care of the overhead. They don't have to deal with all the bills. Very large companies in finance, in technology, in telecommunications, in consumer products, even Uber are moving more into healthcare. Companies that you and I would never have suggested would be interested in healthcare, but they are. How does Uber get involved? Well, Uber in the sense that in some cities it volunteers now to absorb the cost of delivering medications to patients. Maybe it's just a cheap goodwill gesture. I don't know, but there they are. There are even a few hospitals now being built in the United States where there are no beds. There are only rooms where specialists and nurses gather, and are hooked up with patients in their homes with the diagnostic material on the screens, and they collectively focus on these high-needs patients in that way. It doesn't mean there isn't going to be a personal care provider at some point, but the physicians are there, and the patient isn't coming to the bed in the hospital. So to some extent, when we talk about home care, we think of it in the traditional way of having somebody go into the home, but one should also think about care in the home that can be provided, at least the information, so the patient can, to some extent, care for herself or himself, depending on the situation, by the information that is transferred to them by technology in their home. And apps, by the way, apps are popping up all the time, allowing patients at home to request a health call, and from certain providers, get it within 2 hours. In France, it's a variation, I guess, of what they have in France, where family doctors have grouped together, you pay a certain sum a year, and you get home calls for the doctors in exchange of the money you pay them. So all of this, driven in large but not wholly by technology, speaks to decentralizing forces that is, I think, going to press against the bred in the bone, centralized and highly bureaucratic and hierarchical healthcare systems. Every patient, every report I've read over the last, one thing we don't lack for in healthcare are reports, in the last 5 years, has underlined the words patient-centered. You go to bed at night, I'm sure, it's patient-centered. That's what we're going to do tomorrow. And that's true. It's absolutely necessary. Except that, I tell you, in a patient-centered system, if the patients don't find that the system actually is delivering the health care in a timely way that they want, some of them are going to do what Google does to us and go right around the existing system. If you think I exaggerate, probably the best HMO in the United States, which is Kaiser Permanente in Northern California, reports that office visits to their physicians have remained flat since 2008 at about 15 million visits, whereas virtual visits by telephone, secure email, and technology, Skype, etc., have risen from 5 to 12 million. So almost as many visits this way as actually face-to-face interaction with a healthcare professional. So I'm under no illusions about how to regulate all these other services and how to incorporate them into privacy obligations. I merely observe that as new technologies emerge, if this system doesn't incorporate them and use them as they can be used to assist patients and make it more patient-centered and comfortable for them and reduce costs, then people are going to go, to some extent, around the system. I want to just give you one example of a pressure that could come in a patient-centered system. As a population ages, we know about Canada's poor record in wait times. I just gave you the results. You know it all very well. So if people who are older, who know that their time is coming, the Irish say the tap on the shoulder, okay? And they only have X number of years to live, and they need a hip and a knee replacement. And the system says, well, you'll have to wait for a year. But before you wait, you've had to wait 6 months to see the specialist and the surgeon. So you're into a 13 or 14-month waiting period. And you've only got, according to the morbidity tables, 7 or 8 years left. You say, wait a minute. That's your time frame. That's the system's time frame. My time frame is I've only got X amount of years left on Earth, and I want the pain to be alleviated as quickly as possible. And if you can't give it to me, that's your timeline. If you can't give it to me faster than that, then I demand the right to have that pain relieved outside the system, or to have the system changed to permit it to be provided on a faster timeline. And it won't take long for a political actor, believe me, because old folks vote, and young people don't, to stand up and make part of the election campaign that people should be able to go around the system, or that the system should allow clinics outside hospitals to provide this service. If the problem is there isn't enough OR time to provide the services on a more timely basis, people are going to say, then get the operations out of the ORs and get them somewhere else, or get them completely out of the system. And by the way, there's going to be a Supreme Court case which is heading up next year. It'll be before the Supreme Court out of British Columbia, arguing that there should be a parallel private system, which the Supreme Court in its Shawuli decision of some years ago authorized by saying if the public system cannot provide timely care for people who are in need, then the person's rights are abridged under the Charter of Rights and Freedoms. So there's already a precedent there. Now, courts can swallow precedents. Courts can, if you think courts always follow their own precedents, then you haven't been reading too many court decisions recently. So courts can sort of do what they want on this, but nonetheless, one should be aware. Let me just say one or two last things. I'm getting the yellow card here. Here's a counterintuitive thought. As we structure our system for more community and home care, maybe these days we are soon going to be in a situation where we have too many doctors. In some specialties we already have, because they can't find places to practice. There are young specialists now who graduate and they can't find employment, at least not in the large population centers where they want to go. And another debate that I think we're going to have, I think we should have, is how we pay doctors. 30% of physicians now are on salary or adjusted salary benefits. And one of the arguments why physicians are as well paid as they are, and they're extremely well paid in this country by any reasonable standard, is because they say we don't have any pensions. So I would like to see a government put a blue ribbon group together, and Jeff Turnbull can be the head of it, in which we examine the following big deal. You don't have pensions, we will provide them with your contributions and the public's contributions, as with teachers, as with nurses, as with university professors, and you in exchange will receive less money for practicing throughout your life. You say you have to get this amount of money because you don't have a pension. Well, let's talk about this. We're moving in this direction inexorably anyway. Over the next 10 years, let's move as far as we can. Because physician payments between 2007 and 2014 grew by 4.5%, whereas hospitals grew by 2.1% and drugs by only 0.8%. So the cost driver in the system the last 6 or 7 years has been physician remuneration. Let me just end with one thing, 1 minute. I just throw this in because we're having a federal election campaign. We've had it, it's been on for some time, as you know, but officially it hasn't been called yet. If one of the leaders hasn't been to Stratford, he'll be here soon. What are they going to say? Well, the Conservatives in, I think, 10 days down in Charlottetown are going to release the report of on innovation in the healthcare system, led by David Naylor, who used to be president of the University of Toronto, Dean of Medicine, Dr. David Naylor. And that'll be a very interesting report. But I fear it will be one of those reports that's kind of with all the others that get read but not much gets done, because the federal government's capacity to actually deliver innovations is quite limited, but it might get cherry-picked by some of the provinces. The Harper government has the funding formula reduction that I talked to you about, and I don't think there's going to be much more, because they don't consider this to be something which is a big vote winner for them. The NDP is going to recommend, I think, national pharmacare on the rather fanciful, in my view, theory that national pharmacare actually would save us money, which belies the experience of all other jurisdictions in the world, including our own. But they're going to recommend that. And they're going to recommend that we go back to the 6% increases each year, and they're probably going to try to target some of that additional money into something like home care, something like that. And the Liberals haven't yet revealed their hands, but that can be said in many areas for the Liberals. I'm happy to take any questions. Thank you. So please object or inform or ask questions or whatever you wish to do for a couple of minutes before we have a break. I hope I haven't put you all to sleep, which I've been known to do. Yes, sir.
Thank you, Jeffrey, for an excellent and thought-provoking...
Mic on?
Is it on?
No.
Is there a switch here? I used to be a Boy Scout leader. I could talk to 1,000 boys and they'd all hear me. So
Okay.
I'm disappointed in one aspect, that neither Michael before you or you have mentioned anything about the Canadian Index of Wellbeing and about the issues of food security and poverty and their impact on the health system and health costs. And the studies that have come out in Hamilton, promoted by the Hamilton Spectator, have clearly shown, you suggested that seniors take up a lot of the healthcare costs. I think a truer reflection is that poor people take up a lot of the healthcare costs, and alleviating, and even when you look at the seniors, it's those seniors on low incomes that are going to take up more of the healthcare costs. What do you suggest we need to do to address this issue?
So I know that my friend Jeffrey Turnbull will talk a lot about that, and he should. And everything you've said is correct. The incidence of use of the system is almost directly related to your income. The severity of the multiple problems you might have is linked to your income. If one talks about prevention, one really is talking often to people who take very good care of themselves, who tend to be more better off people, who life hasn't thrown as many curves at. I haven't said anything about something which overlaps with what you said, which is mental health. And our paper's just done a very commendable long series on this subject, because there's a big correlation between lower income, mental health, homelessness, etc. So all of that is absolutely true. Totally true. The comment I would make, and have thought about this, is why don't we talk about poverty anymore? I mean, the Liberals are attracting votes, they hope, by focusing the anxieties of the middle class. And the NDP has running an ad in which an avuncular Mr. Mulcair, sitting at a table, says, I grew up in a middle-class family. And I know what middle class, or I'm paraphrasing, I know what middle class values are, and I want to bring those values and help people like my family. The word poor, the word poverty seems to have been banished from the political lexicon. The Liberals, if I may make a political comment, want to raise taxes above people over 200,000. You can say whether that's a good or a bad idea. But assuming that you collect a certain amount of money, and you always collect less than you think you do when you make that kind of promise, but whatever money you make, they're not saying transfer it to poor people. They're saying a transfer to the middle class, which they define as people who earn up to $80,000. This is the first time I've ever heard a redistribution policy to take money from better off and give it to the middle class. That's not traditionally what redistribution is all about. So we've somehow lost the capacity in this country to even talk about poverty, poor people, and the policies that flow from that, including focused health care, homelessness, et cetera, mental health. I find it to be the big, everybody's talking about, pensions and all of which is fine, and the anxieties of the middle class, and so I totally agree with you, and I'm distressed that we just don't seem to be able to get that back on the table. And even the New Democratic Party that grew up, I thought, from my history books and from the time I was around them, as a party that liked and wanted to talk about this, they don't talk about it anymore. So where did it go? You tell me. You're all good citizens of the province of Ontario. Where did those words go? Because they have disappeared. Oh, sorry, I thought there was somebody standing there. I had the lights in my eyes. Sorry. Yes, I'll take one more question and then break time.
Let's just test this to see if it's working. I think it is. One of the most positive things that I heard you say this morning was this amazing news based upon your statistics that many people saw themselves as being extremely healthy.
Relatively.
Relatively. Okay, there's a relativity to it. Nevertheless, it's there. And I cast my mind back to the psychology of a man like Maslow, who said we were going to the wrong places to learn what we needed to do to fix things. In his case, it was psychology, it was individuals, but it also transferred to organizations. From your very apparent, well-read view of all of these things, are you aware of any initiatives in which there are groups, organizations, even writers, who are picking up on the successes of the people relatively who are doing so well at a health level over 85? It seems to me there's an opportunity here to go into that territory and find out, why are these people so healthy? So at the end of the day, the only thing we really have to do is to bury them. Meanwhile, we don't have to keep them in the hospitals and spend a lot of money on them. You've given us some amazing statistics on that. It's overwhelming statistics, actually. Can you offer?
I don't know over 85 in particular. I know that there's a whole lot of thinking that's going on, and a lot of it's beyond medicine. Medicine can do a certain amount, but medicine often has to deal with factors over which it has no control. It's like teachers when they have kids who come to class who have problems at the home and aren't properly fed, and the teachers have to deal with it. It's a bit like doctors and nurses, and this system that you all work in has to deal with societal things that get thrown on people. So it's interesting when you listen to some mayors, as I have, they're trying to, particularly in cities where there are older people, a lot more older people, like Sault Ste. Marie or Thunder Bay, how do we design cities and parks to make it easier for seniors to access the facilities? And there's lots of that kind of thinking going on. And as cities get denser, it's easier for older folks to move into the city and not have to, move around in the suburbs as much. So there's a lot of thinking going on. But the point I'm simply leaving you with, and I'm not answering your question, the point I'm leaving you with is, if you think that we are now facing the challenges of an aging population and its impact on the healthcare system, just wait for 15 years from now. But we can't wait for 15 years from now. I would end my whole remarks by saying it's too bad that 15 years ago, because this was a demographic that we knew was going to happen. This isn't one of those known unknowns. This was a known known, that we couldn't have all got collectively our minds around how do we design circa 1995 a healthcare system for 2010-15 that would anticipate and be ready for what's happened. We did it in pensions. In the middle of the 1990s, the leaders, our leaders, got together, political leaders, and said the Canada Pension Plan needs to be put on a sounder financial footing. And that means over 6 years, contributions have to go up. They did rather. The result is that the Canada Pension Plan, through the new board that was created, the Pension Investment Board, is in excellent shape. It's too bad in healthcare, in which the immediate always drives out the long term, that we didn't have that kind of prescience, and now we're doing a bit of scrambling. But in all the thinking that you do in this LIND and elsewhere, think about what this system is going to have to deal with in 10 to 15 years, when the share of older folks, and your population in this part of Ontario would skew even older than the provincial average, will be well over 20%.
Thank you very much. That didn't answer my question.
No, I know.
Maybe
I
some
don't
of
know
the
the
other
answer.
speakers will.
But I'm going to go into politics next, and when I don't know the answer, I'm going to baffle Gab.